Smita, shall we start?
Yes, ma'am, we can start.
Good evening and a very warm welcome to one and all. I, Dr. Ganavi, welcome you again to another episode of the Indian Thyroid Society webinar, that is the Thyroid Clinics, held once a month on Wednesdays. So before we start, let us briefly go through the journey of the Indian Thyroid Society. So Indian Thyroid Society was established and registered in 2003. It's a national body of healthcare professionals with special interest in thyroid disorders, with endocrinologists, endocrine surgeons, nuclear medicine physicians, general surgeons, and ENT surgeons as members. ITS is a member of the Asia-Oceania Thyroid Association and has currently nearly 2,000 members. The executive committee, we have the founder president, Professor R.V. Jaikumar sir, and our current president, Dr. Shashank Joshi sir. So also we have Professor Sarita Bajaj madam, who is the past president, Dr. Arun Menon sir, who is the secretary, and Dr. Mini G. Pillai ma'am as the treasurer. So also we have Dr. Himagirish K. Rao sir, who is the vice president, Dr. Pramila Kalra madam, who is the scientific committee coordinator, Dr. Sujay Ghosh sir, who is the joint secretary. So also in the executive committee, we have Dr. P.K. Jabbar sir, Dr. Krishna Sheshadri sir, Dr. Mohammad Riyaz sir, and Dr. Sushil Gupta sir. Also, Dr. Ashraf Jani sir, Dr. Mohan Shenoy sir, and Dr. Amaya Joshi sir are also members of the executive committee. So the aims of the Indian Thyroid Society is to organize academic activities for healthcare professionals, to promote public education and awareness about thyroid disorders, to encourage research in thyroidology and the publication in the flagship journal, Thyroid Research and Practice. It is another aim is to have the state-of-the-art publications and to award fellowship of the society and to encourage membership of the society. So the ongoing academic activities of the Indian Thyroid Society include the CMEs, the updates, the symposia, and the conferences. The thyroid clinics, initially held weekly, fortnightly, and now being held monthly, have numerous academic programs like journal clubs, case conversations, monologue, dialogue, panel discussion, meet the professor session, quiz, workshop, and CPCs. So the programs organized by the Indian Thyroid Society include the Thyroid Awareness Week, which is observed between May 22nd to May 28th, the World Thyroid Day on May 25th, and the Thyroid Awareness Month annually in January. So the research activities undertaken by the Indian Thyroid Society include the provision of annual grants for original research studies focused on thyroid and related disorders, preferably in the Indian context. And the research grants are available and to apply for these grants, it can be accessed through the website, that is the indianthyroidsociety.in. So the Thyroid Research and Practice is the flagship journal of the Indian Thyroid Society, which is published twice a year in print and online. It has a quick turnaround time with electronic copies available ahead of print. So the fellowship of the Indian Thyroid Society is awarded to the ITS members who have expertise and experience in the field of thyroidology, which will be selected by an expert panel. The eligible members will be conferred the Fellow of Indian Thyroid Society. So the textbooks published by the Indian Thyroid Society include the ITS textbook of thyroid disorders, the editors of which are Professor Sarita Bajaj madam and Professor Rajesh Ratna sir. So the guidelines published by the Indian Thyroid Society include the thyroid disorders in pregnancy, consensus statement of the Indian Thyroid Society, which is published in Thyroid Research and Practice in 2023. The authors include the Dr.
Video is not on.
Sarita Bajaj madam, Sujay Ghosh sir, Pramila Kalra madam, Dr. Arun Menon sir, and Dr. Mini G. Pillai ma'am. So the upcoming guidelines published by the Indian Thyroid Society include the management of subclinical hypothyroidism and the management of thyroid nodules. So the other guidelines published by the Indian Thyroid Society include the guidelines for the management of dyslipidemia and thyroid dysfunction, hypothyroidism and diabetes, guidelines for the management of depression and thyroid dysfunction. So the website of the Indian Thyroid Society can be accessed through the link, that is the indianthyroidsociety.in, which has numerous contents like the links to guidelines, access to ITS journals, records of all the academic events, and the online membership portal is also available on this website. So the membership of the Indian Thyroid Society is awarded to all the MCI registered modern medical practitioners. There are two types of life membership. The amount is 2,950 rupees. The full-time life membership is awarded to the specialists in the field of endocrinology, endocrine surgery, and nuclear medicine, whereas the associate life membership is awarded to all the other registered medical practitioners. So the membership for the applications for the membership are invited online on the ITS website itself. And the details can be accessed through the link that is the indianthyroidsociety.in. So without further delay, now let us start the webinar. So Indian Thyroid Society, the thyroid clinics was initially conducted under the leadership of Professor Sarita Bajaj Madam, and now being conducted under the leadership of Dr. Shashank Joshi sir, who is the president, Dr. Prabhala Kalra Madam, who is the scientific chair, Dr. Mini G. Pillai Ma'am, who is the treasurer, and Dr. Arun Menon sir, who is the secretary. So in today's session, we have two renowned chairpersons with us, Dr. S.V. Madhu sir and Dr. Nishant sir. And moderating the session, we have our distinguished moderator, Dr. Deepti Sharma Madam, for the two case discussion on Graves' orbitopathy and medullary thyroid cancer, with a quiz in between by Dr. Sanjeev Jaiswal. So before we start, let us briefly go through the quiz participation rules as well. To participate in the quiz, having a Zoom app on the mobile device or laptop is essential. You're requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There will be first two dummy questions followed by the actual quiz. The quiz master will display the case or description of the question by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz. All 10 questions will be available when the poll is launched, and answer for all the questions is to be submitted at the end of 10 minutes. To read the case or description, you can close the polls option using the X button and again use the polls option to answer the respective question. So with that, we shall now start the session with the introduction of our two esteemed chairpersons, Dr. S.V. Madhu sir and Dr. Nishant sir. I request the IT team to display the CV. So Dr. S.V. Madhu sir needs no introduction. So sir is presently the director and professor of the Department of Endocrinology, Center for Diabetes, Endocrinology and Metabolism, University College of Medical Sciences and GTB Hospital, Delhi. Sir's area of interest include diabetes, obesity, and thyroid disorders. So can we have Dr. Nishant sir's CV, please? Asmita? So we have Dr. Nishant sir as the co-chairperson for today's session. Sir is presently the Associate Professor and Head Department of Endocrinology, Center for Diabetes, Endocrinology and Metabolism, University College of Medical Sciences and GTB Hospital, Delhi. Sir has numerous awards and achievements to his credit. Sir has received the Dr. MMS Ahuja Award in 2016. Sir is the Deputy Executive Editor of IJM. Sir is also the Treasurer of Delhi Chapter of Endocrine Society of India. Sir has also been awarded the Sudhir Renan Memorial Award in 2011. And Sir has over 40 publications in PubMed Index, national and international journals. So I now request Dr. S.V. Madhu sir to start the session with the introduction of our esteemed moderator, Dr. Deepti Sharma Madam.
Thank you, Dr. Ganvi. Can you hear me?
Yes, sir. We can hear you, sir.
Okay. Firstly, I wish to thank Indian Thyroid Society for, on behalf of Dr. Nishant and myself, for inviting our department to participate in this thyroid clinic, and particularly Dr. Sarita Bajaj and and the leadership of ITS for inviting me in particular. With that introduction, I must congratulate the society for introducing these thyroid clinics, which I'm sure go a long way in empowering many clinical practitioners and even endocrinologists to learn from this exercise. And with that brief introduction, now let me introduce Dr. Deepti Sharma, my old friend, who is going to moderate this session. I've known her for more than 2 decades. She's currently the current consultant endocrinologist at the Manipal Hospital, Bangalore. Earlier to that, she was at the Guwahati Medical College in the Department of Endocrinology and also was a head examiner there in the Department of Endocrinology. She is a member of several international and national endocrine societies, particularly the American Endocrine Society, the Endocrine Society of India, of course, the Indian Thyroid Society, and has been involved in endocrinology practice and care for last 2-3 decades. I invite Dr. Deepti Sharma to conduct and moderate this session. Deepti.
Ma'am, please unmute yourself. Hello. Ma'am,
Can you hear me?
Yeah, now we can.
Yeah. So first of all, thank you very much to include in this special session of Indian Thyroid Society. I thank the sweet introduction of my friend, Dr. S.P. Madhu. So we'll start with, without delay, we'll start with the first speaker, Dr. Seema Dax, and she will present on Graves' orbitopathy. Interesting case presentation. Please, Dr. Seema.
Very good evening to all the respected seniors and faculty members. So I'm going to present the case of Graves' orbitopathy today. Coming to the case details, Mohammad Salim, a 55-year-old male, resident of Mustafabad, Delhi, married, tailor by occupation. His presenting complaints were protrusion of both eyes since 10 months, redness of both eyes since 10 months. History of presenting illness, known case of thyroid disorder for the last 18 months and was admitted with complaints of protrusion of right eye around 10 months back, which was followed by protrusion of the left eye. 1 month later, which was insidious in onset and gradually progressive. It was associated with grittiness and foreign body sensation in both the eyes. Redness in both the eyes started at around same time and swelling around both the eyes. It was associated with pain in eyes on movements initially, now pain at rest as well. It was associated with excessive watering from both eyes. It was associated with diminution of vision. There was no history of impaired color vision, no history of diplopia, no history of ptosis. He was diagnosed as a case of hyperthyroidism 18 months back when he presented with complaints of tremor in both hands, palpitation on exertion, and increased sweating. There was history of weight loss, which was undocumented. There was associated with increased appetite. There was history of heat intolerance. There was no history of diarrhea, no history of neck swelling, no history of hyperpigmentation of skin, no history of swelling or redness of legs, no history of dyspnea, fetal edema or jaundice, no history of gynecomastia or erectile dysfunction, no history of bone pain or fracture. So treatment history at diagnosis, patient was started on tablet carbimazole 10 mg TDS. After starting treatment, his symptoms were gradually improved. So he underwent regular TFT monitoring and dose was gradually tapered. He was then referred to ophthalmology department for ocular complaints and was started on tablet prednisolone 60 mg OD in June 22. And then the steroids were tapered and stopped in September 22. Again, he was restarted on tablet prednisolone 60 mg OD and Diamox in October 2022. But there was no improvement in the ocular or visual symptoms. Then he was referred to our center in December 2022. And that time he was euthyroid and tablet carbimazole 5 mg OD. Past history, there was no history of diabetes, hypertension, or chronic systemic illness. Regarding the family history, there is no history of thyroid disease or other autoimmune illness in the family. Personal history, there was history of reduced sleep with normal appetite, bowel or bladder habits. He was a chronic smoker with 16 pack years. Examination, coming to general examination, pulse rate was 88 per minute, regular, good volume. BP was 120 by 80 mm of Hg, right arm supine position. Height was 163 centimeter with weight of 65 kg and BMI of 24.5 kg per meter square. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. On hands examination, there were no tremors, not warm or moist, though no onycholysis. There was no thickening or redness of skin over the chins, no hyperpigmentation. Coming to thyroid examination, grade 1 diffuse enlargement was there with smooth surface with no nodularity. There was no tenderness, and lower border was palpable and visible. There was no retrosternal extension, no bruit. So this was the eye examination of the patient. Coming to the clinical activity score, on right eye, there was spontaneous retrobulbar pain. There was pain at a specific gaze on lateral movement. There was redness of conjunctiva, swelling of caruncle and plica associated with chemosis. So in the clinical activity score in the right eye was 5/7, as well as in the left eye was 5/7. Exophthalmos was 24 mm in the right eye as measured by Hertel's exophthalmometer. In the left eye also it was 24 mm. The visual acuity in the right eye was 6/12 and left eye it was 6/9. Lid retraction was present, 2 mm in upper eyelid of both the eyes. Lid lag was present. There was legophthalmos. Pupils were bilaterally symmetrical and reactive. There was no RAPD. Color vision was normal. Confrontation test was normal. Fundus examination was within normal limit. On the right hand, we can see the diagram, which is showing the restriction of eye movements. In the right eye, there was restriction of the movements in the upward direction and in the lateral direction, as well as in the left eye, we can see there was a restriction of the eye movements in the upward and the lateral direction. The systemic examination was within normal limit. So coming to the Graves orbitopathy severity assessment. So this is the severity assessment according to the UGOGO 2021 guidelines. According to this guidelines, so the patient has a lid retraction of 2 mm in both the eyelids. There was moderate soft tissue involvement, and there was proptosis of more than 3 mm. So the patient was categorized into moderate to severe active Graves orbitopathy. So diagnosis was Graves' disease with ophthalmopathy with clinically active disease, clinical activity score of 5/7 with moderate to severe disease, currently euthyroid without dermopathy and without acropathy. Coming to the investigations, his HB was 12.4, total leukocyte count was 5,400, platelet was 1.8, his electrolytes, KFT were normal, LFT was normal, calcium and phosphorus were normal. Coming to the lipid profile, he has a total cholesterol of 208, triglyceride of 234, LDL of 154. His serial investigations for thyroid profile, free T3 was 13.8 in September of 21. Free T4 was 5.4, which was very much raised, and TSH was suppressed to less than 0.001. In April of 2022, the free T3 levels were 4.1, the normal range being 2.5 to 3.9 picogram per ml, and free T4 was also raised, but TSH improved to 0.04. His anti-TPO antibodies were positive. When the patient presented to us at our center in December of 2022, his thyroid profile was free T3 was normal, free T4 was normal, and TSH was normal. The CT orbit, which was done by ophthalmology department, was suggestive of bilateral superior actually I'm not able to see bilateral superior rectus and right medial rectus belly appear bulky, and tendinous part of the muscles were normal. There was no evidence of fat standing. Bilateral optic nerves were normal in pores, caliber, and enhancement. Regarding the management of the patients, general measures were done. The patient was provided artificial tears, carboxymethyl cellulose eye drops for the lubrication. Lid taping was done. Head and elevation to reduce the swelling was done. the dark goggles were provided. The psychiatric referral was done in view of smoking de-addiction, as he had a significant history of smoking with 16 pack years, and statins were initiated in view of hypercholesterolemia. Patient was initiated on injection IV methylprednisolone 0.5 gram per weekly for 6 weeks, and tablet mycophenolate mofetil 500 mg BD for 6 weeks, which was followed by injection IV methylprednisolone 0.25 gram every weekly for 6 weeks, and tablet MMF 500 mg BD for the next 18 weeks. So at the end of 12 weeks, clinical activity score was 1/7. The proptosis in the right and the left eye was same, the 24 mm as that of baseline. The visual acuity in the right and left eye was same. The abduction and elevation of bilateral eyes were restricted. Pupillary reflexes were normal. After that, the patient lost to follow up after receiving the methylprednisolone for 12 weeks. But there was improvement in the clinical activity score, and he went to the ophthalmology department for rehabilitative surgery. We tried calling him. Then the patient was said that he is planned for some rehabilitative surgery. However, he was fine. There was no complaints, no ocular complaints in view of activity in the eye. So, conclusion, early intervention is associated with better outcomes in Graves' orbitopathy. IV glucocorticoids is to be preferred over oral glucocorticoids in patient with moderate to severe disease. As in this patient, we could see smoking cessation is associated with better response to the treatment. And combination of IV methylprednisolone and mycophenolate sodium is the updated standard of care in the moderate to severe and active Graves' orbitopathy according to the UGOGO 2021 guidelines. So this is showing the management of moderate to severe active Graves' orbitopathy according to the UGOGO guidelines. The first line treatment, we have to follow the general recommendation. The patient should be euthyroid. Patient should not be hypothyroid or hyperthyroid. Smoking should be stopped, and iatrogenic hypothyroidism should be avoided. So for these patients, 0.5 gram IV methylprednisolone is given every weekly for 6 weeks, along with the mycophenolate sodium, which is 0.72 gram per day for 6 weeks. So this mycophenolate sodium of 0.72 gram is equivalent to 1 gram of mycophenolate mofetil. So if there is a response or partial response, the patient can be patient should be given 0.25 gram of IV methylprednisolone every weekly for 6 weeks, along with the mycophenolate sodium 0.72 gram per day for 18 weeks. So if there is a patient is responding, we can stop the therapy. If there is no response to the initial dose of methylprednisolone of 0.5 gram per weekly for 6 weeks, along with the mycophenolate sodium, so we can proceed to the second line treatment. So in cases of severe active Graves' orbitopathy, we can start with 0.75 gram per weekly for 6 weeks. So if there is response at the end of 6 weeks, patient is given 0.5 gram every weekly methylprednisolone for 6 weeks. If there is response, we can stop the therapy. If there is no response, we can switch to the second line treatment. So once the patients, if there is a response of the patient and response, if the patient is responsive to the immunomodulatory treatment, then we can and patient goes to inactive state, then rehabilitative surgery should be done as needed or required by the patient. So second line treatment for moderate to severe and active Graves' orbitopathy includes we can start we can try giving IV methylprednisolone higher doses at or with the 7.5 gram, or the patient can be tried on oral prednisolone plus cyclosporine or azathioprine, or orbital radiotherapy can be given, or we can try the patient giving teprotumumab or rituximab or tocilizumab. These are the newer biologicals which can be tried as a second line management for moderate to severe active graves orbitopathy. After the disease become inactive, the patient should be planned for rehabilitative surgery. So regarding the IV steroid therapy, so this is from the consensus statement which is given by European Thyroid Association and American Thyroid Association in December 2022. So IV glucocorticoid therapy is the preferred treatment for active moderate to severe thyroid eye disease when disease activity is the prominent feature in the absence of either significant proptosis or diplopia. This is in contrast to the UGOGO guidelines of 2021, in which they recommended IV glucocorticoids plus MMF as a first-line therapy for moderate to severe active Graves' orbitopathy. So however, this the consensus statement has said that the response the RCTs which has been done with the MMF, the response to the therapy has been divergent. So they have excluded the MMF from the statement. Poor response to the IV methylprednisolone at 6 weeks should prompt consideration for treatment withdrawal, and patient should be evaluated for other therapies. Clinicians should be alert for worsening diplopia or onset of DON that have occurred while on IV methylprednisolone therapy. Other therapies like rituximab and tocilizumab, it may be considered for moderate to severe active thyroid eye disease in glucocorticoid resistant patients, in which there has not been any response to the IV glucocorticoids. We can start the patient on rituximab or tocilizumab. Teprotumumab is for the rituximab. They say rituximab is preferred when there is a prominent soft tissue involvement. While the tocilizumab can be considered in case of glucocorticoid resistant patients. It has more effect on disease activity rather than effect on proptosis or diplopia. Teprotumumab is a preferred therapy if available in patients with active moderate to severe thyroid eye disease when there is significant proptosis or diplopia. So teprotumumab should not. The teprotumumab is the first drug which is being FDA approved in 2019 for moderate to severe active thyroid eye disease, in which the prominent feature is significant proptosis or diplopia. It has not been. It should not be used during the pregnancy and for the patients less than 18 years of age. So teprotumumab is IGF-1 receptor antagonist. So it binds. It forms a functional. It binds to the IGF-1 receptor on the extracellular domain, and then it inhibits the downstream signaling pathway. And this IGF-1 receptor and TSH receptor act as a functional complex. So it will prevent the binding of IGF-1 to the IGF-1 receptor, and then it will prevent the further downstream signaling and further reducing the orbital inflammation and retroorbital soft tissue proliferation, and they were helping in reducing the proptosis and diplopia. So this was a study from which analyzed the results of the 2 RCT, which was done with the teprotumumab. In this study, they assessed the they analyzed the outcomes and follow-up data from the 2 RCTs, which were done with teprotumumab. So in both of the RCTs, the patient received IV teprotumumab, 10 initial dose of 10 mg per kg of the body weight for the first infusion, which was followed by 20 mg per kg every 3 weekly for 24 weeks. And then they measured the proptosis, diplopia, and composite index of clinical activity score and the diplopia. So the proptosis, diplopia, and the composite outcome were reduced. So there was 87% 87% improvement in the 87% of the subjects at the end of 28 weeks. They had improved proptosis of more than 2 mm. There was improvement in diplopia of in almost 66% of the patient. There was improvement in composite outcome. There was improvement in the composite outcome in 92% of the patient, and also there was improvement in overall Graves orbitopathy quality of life scale. Other therapies, evidence from the RCT is limited and divergent, but suggests efficacy of rituximab for inactivation of thyroid eye disease and prevention of relapses at more than 1 year, particularly in patients with thyroid eye disease of less than 9 months duration. Regarding the rituximab therapy, they say it should be preferred in patient with prominent soft tissue involvement. And this is regarding the mycophenolate mofetil, they have although the UGOGO guidelines have recommended IV methylprednisolone plus mycophenolate mofetil as the first line therapy, but the consensus statement they have regarding the MMF, they have clearly written that there is a limited data and inconsistent findings to data that were deemed and to be not sufficiently convincing. Radiotherapy is a preferred treatment in patients with active moderate to severe thyroid eye disease, in which principal feature is progressive diplopia. So radiotherapy may also be considered for preventing or as an adjunct to treating DON. Surgery, ocular motility surgery should generally be ocular motility should generally be stable before 4 to 6 months before the strabismus surgery is performed. So it is performed in a stepwise manner. So the ocular decompression surgery is performed, followed by the strabismus surgery, and at last the eyelid surgery. Thank you.
Now, I like to invite from the audience questions related to the Graves orbitopathy. I have one question.
Yes,
Can
ma'am.
I hear, Asmita? Yeah.
Yes, ma'am.
Yeah. Suppose before giving radiotherapy, suppose it is a dawn phenomenon or dawn or something, then what type of precaution you will take prior to that, and any additional medication you have to give before that?
Ma'am, if we are suspecting dawn in the patient, then first we should give a trial of IV methylprednisolone of higher doses of 500 mg or 1 gram for 3 consecutive days. If there is no response to the IV higher dose of methylprednisolone, then we should wait only for 2 weeks. If there is no improvement in the visual acuity from the baseline at 2 weeks, then we should consider the patient for orbital decompression surgery. Although radiotherapy can be considered, but it is not preferred.
It is not preferred, orbital surgery?
Radiotherapy.
Radiotherapy, yeah. Then what will be the next modalities of treatment? Suppose there is a failure of radiotherapy, then what other modalities of treatment you will advise?
Um, ma'am, in cases of DON only.
Don't only.
Um, uh, uh, then, ma'am, ocular decompression surgery is advised only so as to relieve the compression of the optic nerves and
Okay. Okay. So in relation to DON, what is Brett index? This is called Barrett index.
yes, ma'am. Barrett index is Barrett index is we see on the CT scan. So CT orbit we look on the extraocular muscle swelling, and there is the ratio is fine. The ratio is calculated by looking the muscle volume and the orbital volume, and I think Barrett index of more than 3 is
Basically, it is an instrument which measures the optic nerve sheaths.
okay.
Sheaths. That is the one instrument is used, and that identify how much risks of the DON and what will be the future outcome. Okay.
Okay.
Okay. Dr. Madhu, you please add some question.
Now, from my side, no more questions, Dr. Deepti. I mean, anything from the audience you might invite?
Yes. Anybody from audience?
I think basically I'm Dr. Prasanna Kumar. Basically, over so many years, though we have all therapy, there are no large studies to show head-to-head that any other treatment is better than the glucocorticoids. Even combination therapy, there are small studies. Ultimately, if it fails, as she said, surgery, and though we have used 1 or 2 patients of all other therapies, none of them are superior to methane prednisolone, that too given IV, not oral or anything. I think for the last 10 years, the same thing. 1 or 2 patients you may try, but ultimately it is the same thing what we have done 20 years, and no study has showed that any other therapy is superior to. That's what my personal view is. Thank you.
But sir, if high dose of steroid is given, what are the precautions you have to take? Because most your patient is also 55 years age. Will you
Yes,
like to give high dose of steroid, or what are the things you have rule out before giving?
Conditions like uncontrolled diabetes, uncontrolled hypertension, we have to look for underlying baseline liver function test. If there is active transaminitis or a hepatitis, then we should not give the patient IV methylprednisolone because there is a risk of acute hepatocellular necrosis. And also we can do the baseline chest X-ray done so as to rule out tuberculosis in such patients.
There is a question in Q&A. Please look at it. Dr. Deepti?
Sir, tell me, sir.
There's a question in Q&A. Please look at that question. Please.
Okay, okay, sir.
Yeah, good evening. In the chat box, good evening.
Yeah,
in the chat box, there are questions. Dr. Deepti?
Dr. Ganavi, you will say or I'll say?
No, I think you will be asking them, please.
This is Prasidha Dakal, and question is, what should be the improvement in visual acuity after IV methylprednisolone in DON, which we call adequate and can continue with steroids instead of going to the decompression treatment?
So in the consensus statement which is given by ATA and ETA, so they have mentioned, they have not clear-cut defined the adequate response. They have mentioned if it is not improved from the baseline, like that was at the baseline, if from the baseline, if it has deteriorated, or if it has not if it is not improved, then we say the response is not adequate, and we should consider the patient for decompression surgery after 2 weeks of IV methylprednisolone.
Dr. Nishant, do you want to say something? Dr. Nishant, do you want to add something?
Ma'am, with respect, I am not aware, especially as she is saying that if there is any fixed cutoff given for the improvement, but I think it has to be individualized case to case basis. And at least there is some improvement will give some hope to continue, but I am not aware of any specific cutoff.
There is third question, Dr.
Yeah.
Deepti Sharma.
Yes,
Please
sir.
look at chat box.
Yes. Sasi Mauli, may I know that what treatment would be preferred for primary, for thyroid gland, radioactive iodine versus surgery in each mild, moderate, severe TED? And when would you prefer to give or place the treatment for thyroid gland when the patient has TED? Means how gap between steroid and definitive treatment of the gland? Answer this, Dr.
What treatment would you prefer?
How much gap between steroid and definitive treatment of the gland? That is the main question actually. Suppose we are, every time we are saying, we have to control with the steroid before giving radioiodine therapy. And
Yes.
so tell me.
So if there is so if the patient is planned for radioiodine ablation for the thyroid gland, then if there are high chances of the patient if there are high chances of patient being going into if we can stratify the patient whether the patient is having lower chances or high chances. The high chances of going into if there is a high risk of worsening of
Geo.
Worsening of Graves' orbitopathy on the basis of, so we assess whether there is high risk or low risk of worsening of Graves' orbitopathy on the basis whether the patient is having the large goiter is there, or if the patient is having high level of TRAB antibodies, then there are high chances of going into severe GO. So in these patients, we give 0.5 to 0.8 mg per kg of methylprednisolone for 3 months, while those patients who are having low chances of going into severe Graves' orbitopathy, like those patients who are having lower titers of TRAB antibodies, and in which there are no other risk factors. So in these patients, we can give 0.3 to 0.5 mg of oral mg per kg of oral prednisolone for 6 weeks.
Okay. Any more explanation, Dr. Madhu, you want to give?
Basically, I think the question is centered around if you give steroids and give radioactive iodine, there can be a risk, a greater risk and inflammation, and therefore you might want to reverse the order or give radioiodine therapy and then the steroids. That's basically what probably the questioner wanted to know.
Okay. Anything anybody can add on this topic, because this is frequently mentioned in everywhere, all publication, that how much steroids to give, whether it is logical to give steroid prior to radiotherapy and other things. Suppose if it is after remission phase, but still orbitopathy is there, will you want to give radiotherapy in that case without giving steroid?
Sorry, ma'am.
Suppose person is in remission, but
Yes,
orbitopathy is, proptosis is still there.
Yes,
Okay.
ma'am.
In that
Yes, ma'am.
case, do you want to treat with giving radiotherapy?
No, ma'am. If the patient is clinically inactive, then if the patient is clinically inactive and the main complaint is proptosis only, then we should consider for the orbital surgery only, rehabilitative surgery. If the patient is having active disease, then only we go for radiotherapy. So the radiotherapy is being considered for active moderate to severe thyroid eye disease.
Okay, that is okay. But what about the quality of life? Because that is a very important aspect in an elderly person having proptosis all the time, orbitopathy.
Yes, ma'am.
Yeah. How you monitor quality of life? Quality of life.
Ma'am, to monitor the quality of life, there are some scores are there. The Graves orbitopathy quality of life score and certain scores are there in which we can monitor these patients and
Yeah. So there are some charts is there, recommended charts. Even EGOGO also, they are modifying in 2020 on the basis of quality of life also. They have given everything. It is very nicely written. So if there is no, one more question is there, I'll finish with that. The question is why IV glucocorticoids first choice and not the oral glucocorticoids?
Because it has been found in multiple studies that response rate to oral glucocorticoids is around 50% only, while IV glucocorticoids have a response rate of 60 to 80%, and there are more chances of going into inactivity with the IV glucocorticoids as compared to oral glucocorticoids.
Okay. What about the euthyroid orbitopathy, Graves orbitopathy?
Ma'am, euthyroid Graves orbitopathy can be seen in almost 5 to 10% of the cases of the Graves orbitopathy.
Okay. So anything else? Anybody from audience wants to ask any question? Somebody has written that Mr. B. Shrav, if planned for RIA, then we give steroid after radioiodine therapy, right? If planned for RIA,
Yes.
then we give steroids after radioiodine therapy, right? Are you giving a steroid after radioiodine therapy or before that?
We are giving steroids before the radioiodine therapy because there is a risk of worsening of thyroid eye disease. So if so as I said, if there is high risk, if the patient is having high titer of TRAB antibodies, and if there is a longer duration of thyroid eye disease, if there is shorter duration of thyroid eye disease, that is less than 5 years, so these patients are having high chances of going into severe thyroid eye disease, so they should be given higher doses prior to the radioiodine ablation, that is 0.5 to 0.8 mg per kg for 3 months.
Okay. Any more? If there is no any more question, we'll go to the next topic.
Thank you, Dr. Deepti ma'am and Dr. Seema, for a very interesting discussion. So moving on, I now request Dr. Nishant sir to introduce Dr. Sanjeev Jaiswal, who is the quiz master for today's session. So the next session is the quiz by Dr. Sanjeev Jaiswal.
Thank you, Dr. Ganavi. It's a pleasure to introduce Dr. Sanjeev Jaiswal. He is the director of Hormone Clinic and consultant endocrinologist at Ramakrishna Care Hospital in Raipur. He has done his DM endocrinology from the prestigious Seth GS Medical College in KM Hospital. And he also worked as a faculty at the same institute, the current affiliation. He has enabled research record. He's got more than 20 publications, and most of them are there in very high reputed journals like endocrinology and endocrinology as well as CEM. And he has oral presentations, conferences, and we are looking for a interesting quiz by Dr. Sanjeev Jaiswal. Thank you.
So before we
Thank you,
start,
sir.
yes, sir. Before we start,
Thank you, sir.
sir.
Yeah, sorry. Yeah, please.
Yes, sir. Yes, sir. Before we start the quiz, we'll just have a brief description of the quiz participation rules, sir. To participate in the quiz, having a Zoom app on your mobile device or laptop is essential. You're requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There'll be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or description by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz, and all the 10 questions will be available when the poll is launched, and the answer for all the questions is to be submitted at the end of 10 minutes. To read the case or description, you can close the polls using the X button and again use the polls option to answer the respective question. So Asmita, can we have the 2 dummy questions, please? So the first question, in which city is Taj Mahal located? Option A, Chennai, option B, Mumbai, option C, Agra, and option D, Bangalore. And question 2, how many oceans are there? Option A, 8, option B, 5, option C, 6, and option D, 7. So now moving on to the actual quiz, I hand over the session to Dr. Sanjay Jaiswal to conduct the quiz.
Thank you, ma'am. Thank you, Dr. Nishant, sir. Very good evening to all the respected seniors and faculty members. So I'll just share my screen here. So are my slides visible?
Yes, yes, sir.
Right. So the first question is the efficacy of rituximab used in steroid-resistant thyroid or associated oligopathology has been studied in 2 separate randomized clinical studies. One was in USA and one was in Italy. So RCT in USA failed to show the beneficial effect on ophthalmic outcome compared to Italian population. This discrepancy could have been happened due to option A is younger population in Italy, high smoking rates in US population, and high baseline of CAS in US population with severe eye disease. So option D is shorter duration of TAO in Italian population. Coming to second question, the patient characteristics associated with high risk of thyroid eye disease and propensity to develop sight-threatening eye disease in cases of thyroid-associated orbitopathy. Option A is age less than 50 years. Option B is male. C is diabetes mellitus, and D is unstable thyroid function. Coming to third question, which of the following statement is false regarding MCT8 deficiency? Option A is TFT is normal. TFT shows normal TSH, high T3, low T4, and increased T3, T4 ratio. B is a most common cause of death is cardiac arrest. C is a triac completely prevents abnormal neurological development in animal models of MCT deficiency when administered at birth. Option D is contains enhanced MRI of brain shows diffuse residual hyperintense white matter in specific brain region on T2 weighted images suggestive of global delay in myelination. Right. So question 4 is which of the following factor is associated with lower risk of recurrent Graves' disease after treatment with antithyroid drugs for 1 year? Option A is age less than 40 years. Option B is free T4 of more than 3.1 nanogram per DL. And option 3 is PTPN 22cc mutation, and option D is a grade 2 goiter. Right. So coming to fifth question, which of the following statement for thyroid nodule are correct except a focal uptake in FDG PET increases the risk of malignancy as much as 33% in any thyroid nodule. Option B is mean SU max in FDG PET. FDG PET CT is seen in malignant nodule compared to benign lesion. And option 3 is thyroid results in increased number of FNSC of nodule as compared to 88 guideline. Option D is rim calcification with small exclusive soft tissue component increases the risk of malignancy. Right. So I'll be moving to question number 6 now. A 56-year-old woman with widely metastatic papillary thyroid carcinoma returns for follow-up, and she had undergone total thyroidectomy 8 years back, and she had subsequently been treated 3 times with radioactive iodine therapy, and there was no uptake on her post-treatment scan after second and third treatment. However, on recent FDG PET imaging, she had a diffuse lung metastasis throughout both the lungs, as well as widespread mediastinal lymphadenopathy. But she didn't have a brain lesion. Her laboratory test TSH was slightly suppressed, thyroglobulin was highly increased, and anti-thyroglobulin antibody was negative. So, which will be the best line of treatment for her further management? The option A is cytotoxic chemotherapy with doxorubicin and cisplatin. Option B is linvonatinib. Option C is ipilimumab, and option D is palbociclib. So, 6 coming to next 7th question. Following USG findings are seen. As you can see, the USG findings: white night nodule, and Swiss cheese appearance. These are the findings which are seen in which of the following condition? The option A is radial thyroiditis. Option B is acute thyroiditis, and option C is colloid goiter. Option D is subacute thyroiditis. Moving to 8th question, which of the following antidepressant are preferred in patients with hypothyroidism with major depression? So option A is paroxetine, option B is amitriptyline, option C is sertraline, and D is duloxetine. Coming to ninth question. A 34-year-old female presented with 2.5 centimeter of left-sided thyroid nodule, and according to imaging, she had thyroid 4 staging, and preoperatively there was no abnormal appearing lymph nodes in the central as well as lateral neck compartment. She had undergone left thyroid lobectomy and hysterectomy. However, the pathological examination documented of 2.5 centimeter papillary thyroid carcinoma with the Hobnell variant. Which of the following should be recommended for further management now? The option A is molecular testing to determine the next step in the treatment. The option B is a measurement of thyroglobulin and anti-thyroglobulin antibodies. And option C is observation and follow-up neck ultrasound in 6 months. The option D is complete thyroidectomy and consideration for radioactive iodine therapy. Coming to last question, a 49-year-old man, he had incidentally found to have a 2.6 centimeter of thyroid nodule. He had no compressive symptoms. Clinically and biochemically, he was euthyroid, and there was no family history of thyroid disorders. Thyroid ultrasound shows a nodule is isoechoic as well as regular margin without calcifications. No abnormal lymph nodes are seen in the neck, lateral neck. The patient elected to observe the nodule, but follow-up ultrasound performed after 18 months shows that nodule has increased to 3.4 centimeter. A nodular biopsy is performed and cytology is reported as Bethesda category 3, the follicular lesion of undetermined significance. However, the cytological material when was sent for molecular testing and showed NRAS pathological variant. So, which of the following is likely to be present in the patient when he undergoes surgery? The option A is tall cell variant of papillary thyroid carcinoma. Option B is diffuse sclerosing variant of papillary thyroid cancer. Option C is benign follicular adenoma. And option D is Hobnail variant of papillary thyroid cancer.
Dr. Ganavi will go for the second
Yes.
presentation.
Session.
Thank you, sir, for the mind-boggling questions. So moving on to moderate the session, second case presentation, I request Dr. Deepti Sharma Madam to introduce our second presenter, Dr. Abhinay.
Second presenter topic is interesting case of multiple endocrine neoplasia. And he's Dr. Abhinay. Abhinay is a senior resident of endocrinology, UCMS and GTB Hospital, New Delhi. Please, Dr. Abhinay, you present your case.
Okay, I'm sharing the screen. Am I audible, ma'am?
Yes. Yes, yes. Yes, start, please.
The screen is not visible. Good evening, everyone. To all the faculty members and all the participants, I will be starting with the case. It is a case of Miss X. She is a 23-year-old female. She presented with complaints of swelling in anterior part of the neck since 1 year. It was insidious in onset, progressively increasing in size, gradually progressive, and it was present on both the sides and it was not associated with any pain. There was no history of any other swelling in the neck, no history of weight gain, constipation, dry skin or cold intolerance, no history of weight loss, palpitations, diarrhea or tremors, no protrusion of eyes. She consumes iodized salt, and there was no history of dysphagia, difficulty in breathing, stridor, or hoarseness of voice. There was no history of loss of appetite, no history of neck irritation or drug intake, no history of episodes of headache, palpitations, and sweating, no history of renal stones, bone pains, or fracture. Past history was not significant. In family history, there was no history of hypothyroidism or hyperthyroidism in the family. There was no history of fractures or renal stones in the family, and there was no history of sudden death in the family. So this is the pedigree chart of the patient. Here we can see this is the index stage. On the paternal side, paternal grandfather had a history of thyroid cancer. Exact cause is not known, but they were saying that grandfather had a thyroid cancer and he was operated. Paternal aunt of the patient had abdominal tumor. Exact nature of it is not known, but some surgery was done for abdominal tumor. And paternal uncle died of a lung cancer. On maternal side, there was no significant factors. Personal history, she consumes mixed diet, normal bladder and power habits, adequate sleep, no history of alcohol, smoking or substance abuse, menstrual history was not. On examination, pulse rate of the patient was 84 per minute, which was regular. Respiratory rate was 14 per minute, which was regular. Blood pressure was normal, both in sitting and standing, and there was no postural fall of BP. Weight was 51.5 kg, height of 153.5 centimeter, and BMI of 42. There was no pallor, icterus, cyanosis, clubbing, lipid neuropathy, or edema. No tremors, dry skin, or eye signs of Graves' orbitopathy. There was no cutaneous amyloidosis, mucosal neomas, or macular diabetes. Spine and rest of the skeletal examination was normal. On local examination, there was a 4 by 3 centimeter swelling in the neck. It was moving with deglutition. It was firm, non-tender, nodular. Lower border was palpable. Skin of the swelling was normal. The nodule which was palpable was in the right lobe of thyroid. It was 2 by 1 centimeter in size. It was firm in consistency and margins were well defined. Rest of the systemic examination was within normal limits. So coming to investigations, on baseline investigations, HbA1c platelets were normal, RFTs were normal, calcium and phosphorus were also normal. Initially, TFT was normal, slight elevation of TSH was there. So coming to ultrasound neck, here we can see on the right side of the thyroid gland, there was a heterogeneous solid hypoechoic lesion of size 2.4 by 1.9 by 1.6 centimeter, with foci of internal calcification, which was whiter than tall. So it was a high risk nodule with the thyroid score of 7. There was another solid hypoechoic lesion in the upper lobe of upper pole of left lobe of thyroid. It was measuring 1.2 by 0.7 by 0.7 centimeter. It was wider than tall with well-defined margins. It was thyroid spore. So FNAC was done from the right nodule. It was non-USG guided FNAC. Here we can see the FNAC slide of the patient. It is a grossly cellular smear with a benign appearing follicular epithelial cells with abundant cytoplasm. So report was given to have benign adenomatous goiter. But as the patient had a high risk nodule and the patient was also apprehensive and anxious, so right hemithyroidectomy was done from the ENT side. So histopathology examination of the right hemithyroidectomy specimen. Here we can see a solid pattern of cells. These are arranged in cells and course or nest of cells. Shape of the cells is more or less oval, polygonal, and these are here we can see extensive vascularized stroma is also present. If we see this on the high power slide, here we can see the nuclei of the cells as well. These are here we can see the salt and pepper pattern in the nuclei. Cells are spindle shaped also and polygonal also. And cells are present in nests and spores. Here we can see the amyloid material which is deposited also. So it is consistent with the histopathology of medullary thyroid cancer. So staging of P-T2 was given and medullary thyroid cancer was given. So following this histopathology report, patient was then referred to our department. Initially, she was following in ENT department, and after that, her workup was done. It showed a calcitonin and CA levels which were elevated. So calcitonin was 60.2 with normal range being 0 to 11.5. CA levels were also raised, which was 20.6, normal range of 0 to 2.5. As she was a young patient and had a family history of thyroid cancer also, so the possibility of familial medullary thyroid cancer was kept, and other syndromic association of MEN2A were also ruled out. Her calcium, phosphorus, and parathormone levels were normal, thus ruling out hyperparathyroidism. 24-hour urinary metanephrine and normetanephrine were also within the normal range, thus ruling out pheochromocytoma. She had a primary hypothyroidism picture. Then 18 FTG PET was done to rule out metastasis. Here we can see a faintly avid FDG nodule in the upper pole of the left thyroid lobe. Also, there were bilateral cervical level 2, 3, 4, 6 lymphadenopathy, largest of which was 1.2 by 0.7 centimeter. Some of these lymph nodes were FDG avid, some were non-avid, and avid ones were also showing low activity. There was no evidence of any other hypermetabolic lesion in any other part of the body. So final diagnosis of medullary thyroid carcinoma, familial. with the staging of T2, N1B, and 0, with primary hypothyroidism was kept. Completion thyroidectomy with bilateral cervical lymph node dissection was done following this workup. So here we can see the histopathology slides of left hemithyroidectomy sample. Here also we can see extensively vascularized stroma with a solid pattern of cells arranged in nest and spores. This is the high power view. Here we can see nicely the salt and pepper appearance of the nuclei, which is consistent with neuroendocrine tumors. Synaptophysin and chromogranin stains were also positive. So this shows this was a neuroendocrine tumor. So diagnosis was consistent with medullary thyroid cancer. So, but the lymph nodes which were sent for histopathology specimen were all negative for the tumor. So the final report was PT1B and 0 and MS. As the high suspicion of familial medullary thyroid cancer was kept, so possibility of MEN2A or 2B was considered, and the clinical exome was sent. Patient was positive for RET mutation in exome 11. There was a variant of 634 phenylalanine variant. 634 is the most common mutation observed in patients with MEN2A, and it was a pathogenic variant. So post-op, her calcitonin came down to normal. It was less than 2, so it was undetectable. CA has also decreased. Post-op calcium was normal. There was no hypoparathyroidism, and ultrasound was normal. So diagnosis of medullary thyroid cancer with RET mutation positive, cysteine 634 phenylalanine, MEN2A was kept. Staging of T2 N0 and stage of 2 was kept. So current plan for patient is to continue lifelong thyroxine supplementation. Calcitonin and examination of and ultrasound of neck will be done 6 monthly for 1 year. And if these are normal, then annual follow-up with calcitonin and USG networks will be done. There, as patient is positive for cysteine 634 mutation, so there is a high risk of are developing pheochromocytoma and hyperparathyroidism. So workup for both will be done annually. And patient has been called, and family members will also be screened for the same mutation. So this is the flowchart showing approach to patient when FNAC report shows the medullary thyroid cancer. Here FNAC did not show this feature. So normally, if we get the MTC in FNAC report, then we first have to do ultrasound neck to rule out any cervical lymphadenopathy or local invasion. Then we have to measure the levels of calcitonin and CEA. Then DNA analysis for red germline mutation will have to be done. If patient is found to be RET positive, then we will have to evaluate the patient for pheochromocytoma as well as hyperparathyroidism. If patient has pheochromocytoma, so firstly, adrenalectomy will have to be done prior to total thyroidectomy. Then if hyperparathyroidism is found, then treatment for the same will be done at the time of total thyroidectomy. If both are negative or if the red germline mutation is negative, then we will have to look for calcitonin levels. If calcitonin levels are less than 500 picogram per ml, then we will proceed with total thyroidectomy with or without cervical lymph node dissection, depending on ultrasound, calcitonin levels, and intraop findings. If patient there is a high chance of loco-regional recurrence, then we can consider adjuvant external beam radiotherapy to the neck. This is mainly preferred if there is extensive nodal disease, there is residual medullary thyroid cancer, or extension of MTC beyond thyroid. If calcitonin of the patient is more than 500 picogram per ml, then we will have to do imaging to rule out metastasis by MTC. If there is no metastasis, then similar management will have to be done, total thyroidectomy with or without lymph node dissection. Then we can consider EBRT if there is extensive nodal disease, residual MTC, or extension beyond thyroid. If metastasis is present, then we will have to treat the regional disease. If management will depend on the site of the metastasis. If there is progressive systemic disease, we will have to subject the patient to systemic therapy with tyrosine kinase inhibitors, or we can enroll the patient in a clinical trial. So this is showing the post-op follow-up when total thyroidectomy has been done, how to follow up these patients. So firstly, we will have to do a physical examination and ultrasound of the neck, and serum levels of calcitonin, CEA, and TFT, TSH will have to be done. Post-op calcitonin is usually done at 3 months of total thyroidectomy, because it is usually said that it has long half-life, and nadir will be reached at around 3 months of post-thyroidectomy. So first, we will have to measure calcitonin at 3 months. If calcitonin is undetectable or it is within the normal range, then we will have to do physical examination. And if physical examination, ultrasound, calcitonin remain normal, then every 6 months we have to follow up for 1 year, then annually. If calcitonin is more than 150 picogram per ml post total thyroidectomy, then we will have to do imaging to detect any metastasis. If calcitonin is increased, but it is less than 150 picogram per ml, and we cannot find any evidence of persistent or recurrent MTC on physical examination or ultrasound, then we will have to do physical examination ultrasound every 6 months. We will have to measure calcitonin and CEA every 3 to 6 months to determine the doubling times. Calcitonin doubling time has been shown to correlate very well with the prognosis. Those who have calcitonin doubling time of more than 24 months have very good prognosis, as compared to those who have less than 6 months doubling time, they will have a poorer prognosis. If any time calcitonin raises to more than 150 picogram per ml, then we will have to do imaging procedures to detect recurrent MTC. So if imaging is positive, then we have to consider treating regional disease by surgical resection, EBRT, or other modalities depending on the site and associated risk. And again, with progressive systemic disease, we will have to give a systemic therapy. So, learning points from this case are, firstly, we will have to look for family history of thyroid cancer in case of thyroid nodules, and especially in young patients. So, if we have found any family history of thyroid cancer, then we should be alert to the possibility of medullary thyroid cancer, as it is known to be a familial cancer in around 25 to 30% of the cases. Ultrasound is the most important investigation and evaluation of thyroid nodule. Here, ultrasound was showing a high risk nodule despite FNAC being benign. So, ultrasound, and it also is useful to detect the cervical lymph node metastasis. FNAC from thyroid nodule should be done under ultrasound guidance before subjecting the patient to surgery. So ideally, in this patient, firstly, ultrasound guided FNAC should have been done. If it would have been able to detect medullary thyroid cancer, then we would have ruled out pheochromocytoma. Luckily for this patient, she did not have pheochromocytoma, and she did not go into crisis at the time of surgery. Pheochromocytoma has to be ruled out before proceeding for surgery for MTC, especially in young patients. Genetic testing for RET mutation should be offered to all patients with MTC, especially in young patients. And post-op, patients should be regularly followed up because there is high chance of recurrence in these patients. So it has to be followed by examination, ultrasound, calcitonin, and CEA. Some other cases which we have encountered recently to show the spectrum of MTC. A similar case was seen in which 26-year-old female was there who had a thyroid spore lesion. FNAC was here, ultrasound guided FNAC was done, which was again showing benign. But as patient wanted surgery, so hemipharyngectomy was done, which again showed MTC. And as we know that MTC is a very aggressive malignancy. So luckily in these two patients, there was no extensive metastasis was seen. But here we can see a one patient, 20-year-old male, who presented with neck swelling since 1 year and had a history of weight loss. His workup showed medullary thyroid cancer with lymph node, hepatic, and bony metastasis. So young male with presenting with extensive metastasis. Similarly, a 38-year-old female was there who presented with swelling in the lateral neck, and she was diagnosed to have metastatic MTC from the lymph node swelling also. So this shows that patients who are diagnosed early and treated early have a better prognosis as compared to those who present late. Thank you.
Thank you, Dr. Ravinan. My question is that in spite of knowing strong family history of cancer, thyroid cancer, and two
Yes.
other cancer also, why you're not going straight away to genetic study of this your case?
Ma'am, she was given the option of genetics initially also, but initially they were not willing for genetics because they were more concerned about cancer at that time, so they wanted to undergo surgery. After surgery, we again counseled them, and at that time she consented to genetic testing.
So this is very important. No, sometimes without doing calcitonin, also genetic study will be more informative in this case. Secondly,
Yes.
yeah, and when you have done calcitonin estimation after patient before surgery or after surgery?
Ma'am, it was done post right hemithyroidectomy. It was elevated to 60 picogram per ml. And after completion thyroidectomy, total thyroidectomy also after 3 months we are done. At that time, calcitonin has returned to normal use.
So after surgery, you mentioned that this 6 months after surgery should be repeat of calcitonin. But is it
No.
6 months or 3 months?
Ma'am, it should be done after 3 months post total thyroidectomy. If 3 months value is normal, then we have to do for 6 monthly for 1 year. And after, if both of these are also normal, then we have to do annually.
Okay, good. And you are not mentioning about the extrathyroidal manifestation like Hirschsprung's disease or your CEO, whether it is present or not. You are not mentioning anything extrathyroidal manifestation of this.
Ma'am, in examination, I mentioned she did not have any cutaneous like an amyloidosis, no mucosal neuroma or marfanoid habitus was there, and there was no history of constipation also.
Where is the most prominent site for CEO? Means cutaneous, your embryonic antigen?
Sorry, ma'am?
What is the manifestation of cutaneous embryonic amyloidosis?
Most commonly, it is seen in T2 to T6 areas of interscapular area. It is an intensely pruritic lesion, which is seen in the interscapular area. Mostly, it is seen in T2 to T6 dermatomes.
This skin stage, changes happen that only, not in the back nape of the neck. This happen usually showing that one. Lots of pictures are also showing, and I have seen
Yes,
one case also.
Usually, ma'am, it is seen at the back in the interscapular or at the neck area, but they can be present at other sites.
Yeah. Now I'm opening the question for audience. Any question from audience? Dr. Nishant, you want to add anything? Dr. Nishant,
Yes, ma'am.
you want to add anything in this presentation? Especially in relation to the imaging technique, which one will be preferable, whether it is CT, MRI, or any your imaging other techniques?
I would like to ask him about functional imaging. Is there any role of other than FDG PET, other functional imaging for neuroendocrine tumors?
Yes, sir. Actually, now DOTA, TATE or DOTA NOx scans have come up, which have shown better sensitivity in detecting metastasis than FDG PET. FDG PET is usually useful for defining the exact location of the tumor, but sensitivity of in multiple studies it has been shown that sensitivity of DOTA, TATE and F-DOPA was also F-DOPA was also superior to FDG PET. F-DOPA was able to predict occult metastatic foci as compared to FDG PET. So, if available, F-DOPA or DOTA NOC or DOTA TATE should be preferred as compared to FDG PET.
Okay. Here is one question from audience. What would be your investigation of choice for imaging if the diagnosis of MTC was made on the initial FNAC, whether it is CCT, neck, thorax, abdomen, pelvis, FDC, DOPA, DOTANUT, and PET scan?
Ma'am, usually the metastasis of MTC is usually in lungs, liver, bone, and brain. So no single investigation has been shown to detect the metastasis more accurately than the other. We can do individual investigations for if for lung metastasis or mediastinal lymph node metastasis, CT can be done. For liver, ideally, 3D helical MRI sequence is a better investigation. For body metastasis, bone scan is a good investigation. But if we have to go for one, then DOTA NOC is a good investigation. It has shown sensitivity of around 88% in one study and 68% in other studies. But no clear-cut guideline is there that one investigation is clear than another.
Yeah, which is the complicated type of surgery, like whether when after removal of tumor and searching from the lymph node spread metastasis, okay, whether it is lateral side nodes or it is a central node.
Ma'am, mostly depends on the location of tumor. The tumors which are located in the superior pole of thyroid usually metastasize to the lateral lymph node, whereas those in the middle and lower poles of the thyroid usually metastasize to the central node. So mostly the patient who present with the thyroid nodule type of picture with MTC, central lymph node metastasis is present in 70 to 80% of the cases. So mostly prophylactic central lymph node dissection is done along with total thyroidectomy. Lateral lymph node dissection is done if there is evidence of lymph node metastasis on examination or imaging. And also sometimes it has been said that it depends on calcitonin levels also. If lymph node metastasis is absent and calcitonin is more than 20 or 30 picogram per ml, then we can consider lateral lymph node dissection also, but there is no consensus on this guideline. Mostly it has been seen in observational studies that with calcitonin of less than 20 or 30 picogram per ml, lymph node metastases are usually not present.
I want to ask a comment from Dr. Madhu. You want to give some comment on this?
No specific comment, but regarding the long-term follow-up, how long do you continue to follow up, and when do you expect the other manifestations like FEO and hyperpara to develop in these patients?
Sir, there has been weighted age of presentations of pheochromocytoma and hyperparathyroidism. For example, PO has been detected as early as 8 years in patients with cysteine 634 mutations and as early as 12 years in methionine 918 mutation. But if you look at the most common age, mostly they present in between third to fourth decade. In Indian cities also it has been seen when KEM and CMC cohorts, mostly pheochromocytoma mean age of presentation was around 40 years. So we have to, at the upper range, it has been seen in patients of around 70 years also. So mostly lifelong follow-up will have to be required in these patients, especially in patients with cysteine 634 mutation, because there is high penetrance of pheochromocytoma in patients with as well as the hyperparathyroidism in cysteine 634 mutations as compared to other mutations.
Okay. There is one last question probably. Time is there, Dr. Madhu. I think it is over already. One last question that what about the prenatal counseling? Suppose a pregnant woman who has a earlier history of MEN2, how you will do the calcitonin to prevent for early diagnosis of neonatal MEN?
Ma'am, prenatal counseling has been recommended. The patient should be given the option of invasive sampling from by amniocentesis or chorionic villus sampling to detect this mutation. Even the maternal from maternal blood also fetal DNA can be extracted and mutation screening can be done. Concept of pre-implantation genetic diagnosis has also been there, in which we remove one of the cells from the blastocyst, which is the 8th cell stage. And in that also we can do the genetic screening, and this way we can eliminate the disease from the family if this is found to be positive. Then the further transmission of disease can be prevented. But these have been used in very less cases pre-implantation diagnosis. But prenatal diagnosis with CVS or amniocentesis can still be there. Patient should be given the option if he or both of them are doing.
And you can do it at birth also.
Yes,
right,
ma'am. if they are not willing for prenatal diagnosis, then ideally they should have red mutation screening after birth. The patient with the highest risk, which is methionine 918, they should have red mutation within first year, because it is an highly aggressive and prophylactic thyroidectomy will have to be done in the first year. Those which have high risk mutation like cysteine 634 or alanine 883, red mutation screening ideally should be done in less than 3 years of age. And prophylactic thyroidectomy should be considered at less than 5 years of age if these mutations are positive.
Yes. So I think we can, Dr. Ganavi will wrap up or?
Yes, ma'am. Yes, ma'am. Indeed, it was a very captivating discussion, madam. Thank you, Dr. Deepti ma'am and Dr. Abhinay for this discussion. So we shall now the discussion, the quiz answers by Dr. Sanjeev as well, sir. Over to sir to discuss the answers.
Right. Thank you, ma'am. Just a minute. Yes. So, thank you, ma'am. So, answer for first question is option D, the shorter duration of TAO in Italian population. For the question 2, answer is A, age less than 50 years. And for question number 3, MCT8 deficiency, the most common cause is death is cardiorespiratory arrest happens. It is because of neurological disease, not primarily related to cardiac cause. Option for question number 4, option C is correct. PTPN 22C mutation. For question number 5, TARADS, option C is the answer. The TARADS results in increased number of FNAC of nodule compared to ATA guideline. And for question number 6, so this linmatinib is one of the drugs which has been approved for metastatic papillary thyroid carcinoma in the patient who don't respond to any other treatment. This is well published in this from our society guideline, and this is I have taken from the Indian Thyroid Society Journal. So this is option is subacute thyroiditis. And coming to option number question number 8, the option B is correct. That is amitriptyline. So patient with hypothyroidism and depressions, we should always try to give tricyclic antidepressant, because SSRI which are commonly used like sertraline, duloxetine, they are known to cause they inhibit the absorption of levothyroxine, and some patient may require increased dose of levothyroxine because of that. So patient with hypothyroidism should always be given if given antidepressant should always be preferred tricyclic antidepressant. So for question number 9, the Hobnell variant of papillary thyroid carcinoma is one of the variant which has high risk of malignancy and metastasis. So patient with Hobnell variant should undergo total thyroidectomy and followed by radioactive iodine therapy. So the option for question number 10 was benign follicular adenoma, because NRAS variant is known for well differentiated. It is a marker of well differentiated tumors, and which is among all the 4 options. Option 3 is a benign follicular edema, which is benign lesion. So I'll be discussing the other 5 questions which was for teaser purpose. So these are the 5 questions. The first question, which was a teaser question. So option 4.
So we are not able to see the slides.
Okay, just a minute.
Still on number 10. I think it hasn't moved.
Right now, I hope this is it is visible now.
No,
No?
no. I think you just close and open again.
Okay.
Stop the sharing and share.
Not as visible, ma'am?
Yes, this is 37-year-old woman.
Yeah, right. So this was a teaser question. 37-year-old woman with right-sided thyroid nodule of 3.2 centimeter, and there was family history was negative for thyroid cancer, and BP was normal, and lab results calcitonin was slightly increased. It was less than 500 although, and calcium and plasma metanorphins were normals. So as we know that a patient who have a calcitonin level less than 500, the risk of metastasis below the neck is less. So this is reported that none of the patient have metastasis below the neck if calcitonin level is less than 500. So such patients should be offered a neck ultrasound to see local regional lymph nodes, not gallium dotatate and not FDG PET and other options available. So this is second question. All of the following genetic cause of congenital hypothyroidism is transmitted as autosomal recessive inheritance except THOX2 mutation, which is X-linked mutation. This is question number 3. Allen-Harden-Dudley syndrome is caused by the mutation of MCT8 gene. Question number 4. All of the following cause secondary hyperthyroidism except PSH. The option D was correct. Amidon-induced thyrotoxicosis. And the highest risk of aggressive medullary carcinoma is seen in red pathogenic variant. Option D is the 918T mutation. Thank you so much.
So I now request Dr. Sanjeev Jaiswal sir to announce the quiz winners. I request Asmita to display the winners for both the teaser questions and the main quiz.
So today's quiz winners, Dr. Geeta Tomar, Dr. Nilesh Vyas, and Dr. Deepak Avasti. Congratulations to all of you.
No, there will be another set, right?
That is
Okay.
Yesterday's quiz winners.
Okay.
For the
Dr.
teaser.
Lakshmi. Okay, this was for teaser, right? So Dr. Lakshmi S, Dr. Swati Jadhav ma'am, Dr. Reshma ma'am. Congratulations. Dr. Swati Jadhav ma'am is our senior from KM.
Yeah.
Thank you very much, Dr. Sanjay Jaiswal, and for your beautifully conducted the whole quiz program. Thank you.
Thank you, ma'am. Thank you, ma'am.
And thank you, Madam Sarita Madam, for giving me the chance to chair the program. Thank you very much after a long time.
It's a pleasure. It's a pleasure to have you with us. Thank you, in fact. Thank you.
Thank you. Thank you, Dr. Ganevi. You have conducted so nicely whole program.
I think she is quite an expert by now.
Yes.
I now request Dr. Sarita Bajaj Madam and Dr. Pramila Kalra Madam to give the concluding remarks.
Pramila?
Yeah, ma'am, you can say, ma'am. From my side, I thank everyone. It was really a nice discussion today. Dr. Madhu sir, Dr. Deepti ma'am, and we had Dr. Nishant with us. So we had a really nice discussion and the quiz was fantastic. And also the two students did a very nice job with the case presentation. And as usual, Dr. Gandhi, as usual, Dr. Gandhi also conducted the program very nicely. And I again request everybody and all the audience also that if you have any journal articles, any review articles, any case reports, we have the Journal of the Indian Thyroid Society, that is Thyroid Research and Practice. The website is working. You can upload your articles online. It is a peer review process which happens. We are trying to get our journal indexed. So please help us by sending your articles so that we can get it indexed faster. So that is a request from my side. So I hand it over to ma'am.
Thank you, Pramila. So the editor of the Indian Journal of Endocrinology and Metabolism is with us, Dr. S.V. Madhu. I think he needs to share a few tips with us as to how we can get it indexed.
No, the
We are
IJM was
struggling with
indexed. IJM was indexed before I took over, so I can't give you any more tips. Basically, what she's requested people to do is the first thing, I think. More articles, more peer review, better reviewed articles as they keep coming. The indexing process is a natural
Yes.
consequence.
Actually, for the last more than a year now, since I took over, we've been trying to do that. And we're trying to get more and more articles in place. We are every program, if you note, so even the quiz, we had requested Sanjeet, and he categorically mentioned that one question is from TRP, from Thyroid Research and Practice. So this was one way of encouraging, participation and, spreading the awareness. But we're still struggling. So I think you can only wish us the best, because I think Pramila and Krishna are really, really working hard. Right. So anyway.
It will happen soon, madam.
Yeah, it takes time. Thank you. Thank you very much. So a very special thanks to Seema for that. Both the cases were very interesting. The challenges, see, graves of ophthalmopathy. I think I agree entirely with Nishant that every case, it has to be managed on a case-to-case basis. So there's no, of course, the guidelines are there, and the UGOGO guidelines and the recent guidelines, with the December 22 guidelines were being discussed, the differences between the two of them. And Dr. Prasanna rightly said that, there's no head-to-head comparison. So as of now, it is corticosteroids, parenteral steroids, which are the mainstay of therapy, depending on the CAS or the clinical activity score. And so a very special thanks to both the senior residents, Seema and Abhinay, for the interesting patients, that medullary thyroid carcinoma as well. I think, thank you, Dipti, for your excellent moderation, and Dr. Madhu and Dr. Nishant as chairs. Congratulations to the quiz winners. And I think, of course, Pramila, Arun had also joined us. I think he's still there. Minnie was with us, and Pramila. Thank you. Thank you very much. Asmita, she's from the IT. I beg your pardon? Yeah, thank you, Asmita, for being with us for every meeting. And from MediSage, we had Akash. So MediSage is fielding those pre-ITS clinics quiz. So we have as teasers to encourage more active participation in the audience. Thank you, Sanjeet. The quiz was very interesting. So looking forward to the next program. So Ganvi, I think that's what's going to be projected next.
Yes, ma'am. So the next session is on 11th of October. So Asmita, can we have the flyer, please? So for the next session, we have Dr. Subodh Bansal sir as a chairperson, and Dr. Jayanti Ramesh sir will be the moderator. So we have two interesting cases on hypothyroidism and a very interesting quiz by Dr. Lisa Das in between. This session will be conducted on 11th of October. The upcoming thyroid clinics, can we have the dates, please, Asmita? Asmita, the upcoming dates? Yeah, so after the 11th October session, we have the upcoming events on 8th of November and 6th of December. So we request each one of you have joined today to participate in the following sessions and make this program a huge success. With that, we conclude. I thank one and all for their active participation.
Thank you. Thank you very much.
Good night. Good night, everyone.
Bye-bye.
Thank you.
Thank you. Good
Good
night.
night.